Our next group of unicellular parasites are the flagellates, and they are flagellates because they are motile through the use of flagella. So instead of pseudopods, they use flagella to move. And the first genus we'll discuss is Giardia. Giardia, as hopefully you can see in this image, is transmitted through the fecal-oral route. They also have a cyst and a trophozoite form. So the trophozoite form has the flagella, but it also will disintegrate in the feces. So patients who develop Giardia infections have ingested a cyst. The cyst will exist in the duodenum, will multiply, and cause infection. And again, then the patient will pass both cysts and trophozoites in the feces, but the trophozoites will eventually disintegrate. The cysts are resistant to chlorine at the concentrations that are typically used in water treatment. We can't use very high concentrations of chlorine in water treatment because it affects the taste and it can cause issues in the people who are consuming the water. It's estimated that approximately 50% of infected individuals are asymptomatic, but in those patients who do develop symptoms, it can be anywhere from a mild diarrhea to severe malabsorption. And I'll show you on the next slide malabsorption of what. They do form the cysts and trophozoites. The infectious dose is anywhere from 10 to 25 cysts. The stomach acid, that pH, is actually what triggers the cyst to become a trophozoite. And then they'll attach to the intestines using a structure called a ventral disc. There's an incubation period of about 10 days from consumption of the cysts, with a sudden onset of foul-smelling, watery diarrhea with unabsorbed fat. So what's happening is as the trophozoites bind to the wall of the intestines, they prevent the absorption of fat, and that fat has to go somewhere. It goes out as diarrhea. Patients will also experience cramps and significant flatulence. So Giardia can often be diagnosed by looking at unabsorbed fat in the feces. Most patients will experience a spontaneous recovery in 10 to 14 days. However, patients who are IgA deficient or otherwise immune compromised might have more trouble clearing the infection. Remember, IgA is the most important mucosal antibody. You can look for cysts and trophozoites in one stool sample per day for 3 days. You can also look for fecal antigen and PCR. And this is what the trophozoite would look like under the microscope. I don't know why, but I know why. It looks like it's smiling. And I'm just picturing this like awful little parasite binding to the intestines and being like, hee hee, look what I can do. So that's how I always remember what Giardia looks like under a microscope. I picture it laughing at me. Treatment of choice is metronidazole. Metronidazole is a relatively common treatment for some of the unicellular eukaryotes. It works pretty well at clearing the infection. To prevent infection, if we don't have appropriate water sanitation, you would want to filter or boil your water to prevent the ingestion of cysts. We typically only see this in the US if a patient has just returned from traveling abroad where they did not filter or boil their water. Our next flagellate is Trichomonas vaginalis. It has 4 flagella, and as you might imagine from the species name, it can be found in the urethra or vagina of women or the urethra and prostate of men. This parasite is a little bit unique in that it has no cyst stage. It can be transmitted by fomites like a toilet seat. However, it's far more common to see sexual transmission. The trophozoite will eventually disintegrate in the external environment. So that's why fomite transmission isn't terribly common and why sexual transmission is far more common. In developed countries, anywhere from 5 to 20% of women and 2 to 10% of men are infected with Trichomonas vaginalis. The majority of women who are infected are asymptomatic or may have a scant watery discharge. However, in some patients, it can cause really significant infection with itching, burning, painful urination, and a foul-smelling discharge. I personally have never worked with this organism, but when I was a master's student, one of the labs did. And I remember one day I was walking down the hall because I needed to go to the classroom where I was a TA for genetics. And down at the end of the hall was the lab that worked with this parasite. And I, rounded the corner to the hall, and I literally had to stop. Like I felt like I physically ran into something. And what I ran into was the worst thing I have ever smelled in my entire life. I thought I was going to throw up. I didn't, but I thought I was going to. To me, it smelled like, and I'm sorry that this is graphic, but this is what it smelled like. It smelled like somebody had eaten like rotten fish. So it had that kind of rotten fish smell, and then had thrown it up. So then it had a vomit smell too, and then left it to sit in the sun in the summer in the valley. So it smelled like rotten fish. It smelled like vomit. It smelled like decay and putrefaction. And my friends were working in the lab, and they had been growing like liter or 2 liter cultures of Trichomonas vaginalis, and they saw me like stop and dry heave, and they just were cracking up because they were so used to the smell, but I definitely was not. So it was one of those that I was like, I don't understand how this disease spreads. It smells so bad that you would think that somebody, if they smelled like that, would seek treatment, and certainly wouldn't be intimate with somebody who smelled like that. But most patients are asymptomatic. They're not going to smell like that. Once you smell like that, you'll know, and you can go get treatment. Most men are also asymptomatic. However, they may experience inflammation in the urethra or prostate, which would lead them to go seek treatment. It can be diagnosed by trophozoites in the discharge. It can be cultured. Again, I don't recommend it. Serology, nucleic acids can also be used as diagnostic tools. It can be treated with metronidazole. However, there are some drug-resistant strains that are emerging. A lot of times, this is actually diagnosed when patients seek treatment for a different sexually transmitted infection, and it turns out they also have trichomonas. But the trichomonas wasn't causing the symptoms. Perhaps it was gonorrhea or chlamydia. So patients can have multi-sexually transmitted infections at a time. Prevention is through increased personal hygiene, so fomites. If you clean up your bathroom, all of that kind of good stuff, and also through safe sexual practices that can help prevent the spread of infection. Our next flagellate is Leishmania. These are obligate intracellular parasites that are transmitted to humans from the bite of sandflies, so specifically female sandflies. There are a number of different life stages for this parasite. When we see a parasite that has these multiple life stages, I'm not going to ask you about all the different life stages because this is not a parasitology class. If you're able to take parasitology, I highly recommend it, and you'll learn about all of these differences. I'm just broadly giving you the life cycle and how you can diagnose and treat the infection. So a patient acquires the infection from a bite. The stage that's infectious in humans is injected into the skin. It will undergo a transformation into another stage of its life cycle, and then it can reproduce and invade other cells. Depending on the species of Leishmania, it depends on where the parasite likes to go. So it can go to lymphoid tissue in the skin, visceral tissue, or skin and mucous membranes. And eventually, if a patient is bitten by another sandfly, the sandfly can pick up the parasite and transmit it again. In the United States, the most common presentation of leishmaniasis is cutaneous. This is what the wound can look like. In some of our patients, if they get this is a giant open wound. So if they get another, like a bacterial infection on top of that, that can complicate healing. It will often heal after a few months. As you might imagine, it can leave a relatively large scar. Can be diagnosed by culture or nucleic acid testing. And the drug of choice is actually parmomycin, which is a protein synthesis inhibitor. Okay. Our last flagellate genus is Trypanosoma. There are two major species of Trypanosoma. Trypanosoma brucei has two subspecies. Both are transmitted by the tsetse fly and are found in Africa, where they cause a disease that we call sleeping sickness. The species we have in the Americas is called Trypanosoma cruzi. It is transmitted by a group of insects, including kissing bugs. And American trypanosomiasis is called Chagas disease. So here's your tsetse fly, here's your kissing bug. Trypanosoma brucei, again, the one that causes sleeping sickness. You have multiple life stages, but a patient is bitten by a sandfly. The life stage that's infectious of the trypanosoma is injected into the body. It will divide. It goes into the blood, the lymph, the spinal fluid. And so that's why it can cause nervous system complications, because it can get into the spinal fluid and the brain. So patients can experience lethargy, tremors, meningoencephalitis, seizures, incontinence, coma, and eventually death. Because it messes with the brain, it also alters the sleep-wake cycle, which is why it's sometimes called sleeping sickness. And what you're looking at here is a blood smear. These are eukaryotic like host cells, and then these are the parasites. Trypanosoma cruzi, which is the one that we have in the Americas, so North and South America, is an intracellular form. So it wants to enter host cells. It replicates and destroys those host cells. You often will see a rash. You can have central nervous system involvement, and you can see size changes in various organs as they swell because of the infection. Patients who get this infection who die often die because of heart block or brain damage. So the transmission of kissing bug infections is a little bit different. So the way Trypanosoma cruzi is transmitted, very, very commonly, they're called kissing bugs because they bite on the face, often near the mouth, in the middle of the night. When they bite, they also defecate. And the parasite is actually in the feces. And so what can happen is if the feces gets into the bite wound, perhaps the patient scratches or feels the bug on their face and kind of like wipes it away in their sleep, whatever. If the feces gets in the bite wound, that's how it gets infected. And then what you can see in this microscope image here is the stage that actually is inside of the tissue. So sleeping sickness would not be found in the US unless you have a patient who's recently returned from Africa. It would be diagnosed by looking for the presence of the parasite in the blood or the cerebrospinal fluid. There are a handful of treatments available. The stronger one, of course, is for central nervous system involvement. Chagas disease is found in North and South America. As of right now, it is rare in the United States. You notice I don't say unheard of, I say rare, because of insect habitation. So infected insects are not as commonly found in the US as they are in other parts of the Americas. But with climate change comes the potential increase in range for some of these arthropods. So it's entirely possible that Chagas disease could become more common in the US with our changing climate. The early infection can be diagnosed by a blood film. You would see the trypanosomes in the blood. You can also do a biopsy of infected tissue and look for those intracellular forms in the infected tissue. There are a couple of treatments available that are more effective during the early stages of infection.